And now it's time to move on for some clinical instruction. And our guest speaker today is Dr. Steve Carstensen. He's been treating sleep apnea and snoring in Bellevue, Washington since 1998. That's when Dave and I were in middle school. He serves as a consultant to the ADA for sleep-related breathing disorders. He's a diplomate of the American Board of Dental Sleep Medicine. He lectures internationally and at dental schools. He is the co-author of the best textbook for understanding dental sleep medicine. It's called The Clinician's Handbook for Dental Sleep Medicine. It's published by Quintessence in 2019. Hopefully he's going to update that soon. It's an incredible textbook. It's readable. You can pick it up and read it. It is a really well-written book. So his lecture today is on a very practical clinical topic, oral appliance selection for snoring and sleep apnea. And I'm delighted to turn over to our friend, Dr. Steve Carstensen. It's all yours, Steve.
Thank you, guys. I really enjoyed this panel, and I took notes from lots of things. And Nicole, I told you this was going to happen. We practiced this, and now the share's not there, so bear with me, guys. It'll be there in a second. And so the Clinician's Handbook is indeed in a second edition editing process right now. So there we go. Can you see my screen okay, guys?
Perfect. Thank you.
All right. So we're going to talk about oral appliance selection for snoring and sleep apnea. And I'll talk to you about what the difference is between those here in a minute. So there we go. And there's my disclosures. I have I work for one of the companies that's involved with what I'm going to talk about today, but you won't know which one that is by what I'm going to say. So there is that in there. There is the magazine, the book over there that I helped write with Dr. Ken Burley. And the second edition will be out sometime this year, if I can get some of my authors to give me the right photographs. And then I'm a contributing author to a book about cone beams, that if you have a cone beam, you should have. They do send me a check on that one, so I have to tell you that. But there's nothing about sales you're going to hear from me today that benefits me in any way. What's most important that we always keep in mind about any therapy that we have is that we must connect it with our patient's perceived benefit. If we don't make sure that what we recommend, prescribe, offer, suggest to our patients is connected with something that they want, then the chances of them picking up the item or doing the thing or that we ask them to do, it goes down. And that's true across medicine. It's true across behavior. And I want you to keep that in mind when you think about which appliance you're going to use for this patient. What is it you're trying to solve? And is it what you're trying to solve or what they need to have solved? And that's a different thing. And you better make sure you're clear on what benefit they're looking for. So the snoring and sleep apnea, when I ask people, what do you want? How do you want me to help you? And what do you want fixed? And they say, my sleep apnea. Well, they don't know about their sleep apnea. That's something that doctors measure. What they know about is the snoring that bothers their bed part. What they know about is the tired feeling they have, those kind of things. And so make sure you get to know your patient very well on that. So Dr. Christopher Lettieri is a physician. He's a real powerful or a prominent physician in our circles. And he gave a lecture a few years ago now to the American Academy of Dental Sleep Medicine. And even many years ago now, they've known for a long time that oral appliances and PAP devices, CPAPs and others, they worked about the same for people. And the outcomes that we get from these two different ways of treating people is not different. So in other words, what we have to think about is what will the patient actually use? And I'm sorry to say that PAP therapy, which is a great way to treat a closing airway, is only used properly by about 30% of people that actually are given a PAP. Now, some statistics will say 50%, and if you ask your physician down the street, they say, oh yeah, like 80%, 90% of my patients use their PAP devices. Well, they're not accurate about that. They're unaware. So we have to think about not which device we're going to use, but actually what the patients are going to actually use. So I am going to talk to you about more oral appliances today because that's what we dentists have a unique part of medicine to be able to provide. I'm going to talk about different things we can do about this, show you some appliances and how you can use them, how you can match those to the patient's perceived benefit. But to make sure we're on the same page, just so you, just to bring you up to speed, we're talking about airways, and we have an open airway. All of you that are listening to this have an open airway right now because you're breathing and through an open space behind your tongue and through your nose. And that is what we wish everybody would do. And about half the population breathes this way every night while they sleep, but only half the population. And the other half of the population has a varying number of events called hypopneas. And hypopnea is where there's less air moving. And so yes, air is moving, but the body has to work extra hard to pull the air through that small space and into the respiratory system and push the air back out through that small space too. And when you push air through a small space with flexible walls, you get a lot of noise, and that's snoring. The definitions of hypopnea also include some desaturations, and so less oxygen in the blood system. And that's really the important part right there. And then we also have apnea events. Apnea events are when the airway is virtually completely closed off. And it's a matter of the body is trying to breathe, but can't breathe. And these are counted as events, and these events must last 10 seconds or longer. And the longer part is the dangerous part, because if we have a apnea event that's 10 seconds and the body wakes up and says, okay, I'll pop that airway open and breathe again, that has not a lot of effect on the physiology. But if we have an apnea event that extends on and on and on, then we get increasingly low oxygen levels, increasingly high CO2, and increasingly impactful brain changes. And so these are very important. My father had a very large count of events, and his longest apnea event was 92 seconds. 92 seconds he was trying to breathe during his sleep test and couldn't because of his apnea. So that gets pretty serious. The traditional measurement of this is called the apnea-hypopnea index, where we count up the number of hypoxia events, how much hypopnea events, how much, and they count up the number of apnea events, divide by the time of the test, and we get a number called an index. And that's important. You have to know the index. That's becoming less and less important as we are realizing the impact of physiology, but it is what we all have to know. There's another index where we look at how much oxygen changes there are and whether it drops 3% or 4%. There's two different ways to measure this, and we're not going to take the time to talk about those differentials today, but we count up these events and we have an oxygen desaturation index, getting a little closer to the actual physiologic impact. And now we're getting a new term coming on called hypoxic burden. And this is going to be, so far, what we think is going to be the right way to go. And this hypoxic burden starts to approach the actual physiologic effects. And what we are counting here now is not how many events where the oxygen drops below a certain threshold, but in fact, how much time the body is struggling with that low oxygen number. It's difficult to calculate right now, but soon we'll have this as part of every sleep report that you'll see and every oximeter report that you'll see. So look for hypoxic burden, because we'll start to be able to help our patients understand that, in fact, their migraines or their dizzy feelings or their lack of energy is coming not from how many times they stop breathing, but how long their body struggled with it. So what's the best way to solve this is to make sure the body doesn't have to work so hard for gas exchange. If we don't make the body work to get air through a small space, then we allow the body to return to what is my favorite word, homeostasis. I like the concept of the body healing itself. I don't really think we do much to heal the body. Now, if we're surgeons and doing and extracting decayed teeth and putting in fillings that we heard a little while ago need to last now for 5 years at least, then we are definitely going to be helping the body heal. But in self-healing tissues, like the respiratory system in the brain, then we just simply get the problems out of the way. And that's what we want to be thinking about when we open the airway, is we don't create a better night's sleep. We don't make the body not have physiologic effects. What we do is we just remove a mechanical blockage. We take the closing airway and make it non-closing. And then the body turns itself into a good respiratory center, and it takes care of the oxygen and CO2 levels the way it's supposed to. So when we think about this little video, I like this little video.
Over 30 million Americans suffer from breathing-related sleep disorders. While you sleep, most of the muscles of the body are relaxed. Sleeping on your back allows the base of the tongue and the palate to drop back and block the airway. When the airway is partially blocked, the flowing air can cause the muscles to vibrate, resulting in snoring. When the airway is completely blocked and no air can get through, it is called obstructive sleep apnea. This condition is very serious because it causes your body to be starved of air, causing unhealthy blood oxygen levels. Snoring and sleep apnea interrupt sleep, causing your brain to be aroused. Poor sleep like this will often lead to irritability, daytime sleepiness, and less ability to concentrate on tasks such as driving. If left untreated, sleep apnea can lead to high blood pressure, heart attack, stroke, and diabetes. Often, sleep apnea is treated with an air pressure mask called CPAP, which helps you breathe by pushing air through the nose and holding the airway behind the tongue open. While CPAP treatment is effective, many people find this therapy bulky, complicated, and uncomfortable. An alternate, simpler solution is a mandibular advancement device, or MAD. A MAD is a custom device made from impressions of your teeth and bite of your jaw. The MAD is worn in the mouth while you sleep and promotes breathing by moving the lower jaw forward, allowing the tongue and other soft parts to be pulled forward, preventing them from blocking the airway. Initially, you may experience some minor tenderness in your jaw or teeth, but these issues are typically a temporary reaction and will usually correct themselves as you get used to wearing the device. Healthy sleep is very important to your overall physical well-being. There are several different types of MAD, so talk with your dentist about all your options on how you can get the best night's sleep.
So these little videos like this, there's a lot of them out there, are important for your patients to see. Because we have something complicated to talk to them about. We're going to give them a device that they might think of as a night guard, but we have a much different goal in place for a mandibular advancement device. And I wrote this video for Guru, patient education software, I guess, oh gosh, probably 15 years ago. And I keep watching it and thinking, that's still pretty good. So we haven't changed much about what we try and do in all the years I've been doing this, but we are learning more and more about the science of it all. So Dr. Danny Eckert is one of our lead scientists in the world, has about these kind of things. He says, look, there's 4 reasons why people have sleep apnea, and 100% of people have some kind of anatomy compromise. Could be how they grew, could be obesity, could be muscle weakness, all kinds of reasons why they have impaired anatomy. And then we have 3 other reasons, 2 of which are brain responses to gas exchange we're not going to talk about, but the ones that we have something to do with help the anatomy, and they help ineffective upper airway dilator muscles. And the primary one of that is the genioglossus muscle, because when that muscle fires, it brings the tongue out of the back of the throat and opens up that airway. So as dentists, we can do something about these 2 areas quite readily, and that's what we're going to focus on here. Because when we have an airway that closes down, what we can do is bring the jaw down and forward. It has to come down, it has to come forward to be able to affect the anatomy behind the airway. Now, if you're kind of new to this and you're thinking about oral appliances for treating your patients with snoring and sleep apnea, and you're not quite, aware of all the anatomy back in the oral pharynx, it's time to get your books out, because it is past the teeth and the gums and the jaw joints, but it has to do with a lot of tissues that you studied in dental school or dental hygiene school if you're a dental hygienist, but you may not have used that knowledge for a little while. So get your books out or go online and learn a little bit more about the anatomy, just so you can remember how to think 3 dimensions about moving that jaw forward. It's important for you to be able to visualize the whole anatomy back there. And as you talk to patients about what things are happening because they simply push their chin forward, and especially how they're going to get their chin back, then you're going to be able to, have that discussion with confidence. Because you have to be able to know about the jaw joint. Now, do you have to be a TMD expert? You don't, but you can't be zero on the TMD and still give them a mandibular advancement device, because there is this side effect of the fact that we hold the jaw forward through the nighttime, and we'll talk about which appliances, but we have to get the jaw back to be able to get the teeth back together and apply our good dental skills to have a consistent occlusion. So if you're not familiar, again, if you kind of lost touch with what the jaw joint does and how it functions and which parts do what, then take a class. Watch some of the videos that Jamison Spencer's put online with Glidewell. He does a great job of talking about jaw joints and real practical information. So I've learned a lot from Jamison over the years, and I know he's been a good partner with Glidewell. So I would consult those if you need a little refresher. But the bottom line is, when you bring the jaw forward at nighttime, they get up in the morning and their teeth may not fit all the way together the same they did the night before. So we have to undo that. And the easiest way to do that I've ever found is a AM aligner from Airway Technologies. And what we have here is a plant-based material called thermocryl, and they've formed it into this little arch form. You heat it up in a minute in hot water, and you have the patients bite into full MIP. And you bite hard on this. You try and bite all the way together in this. You form an imprint of all of the cusps of all of the teeth and the incisal edges and the overjet and the overbite and all these different parts of the occlusion. And then as it cools down, you take it out and cool it down. And then what we have here is a slippery material, the thermocryl, and every slope of every tooth helps to guide the parts back where they came from. So we have our patients get up in the morning and they move their jaws around, so where they, free things up a little bit, kind of like not sitting in one place for a long time. And then we have them exercise on the AM aligner, and they grip on it and they release. And they bite and they release, bite and release. And as those slopes of all of those cusps work against that thermocryl, then the MIP is recovered. And we have lots of patients who don't have a consistent MIP anymore because they didn't do the exercises, but everybody who does the exercises gets their bites back to normal. And we undo the effects of that forward posturing through the nighttime. So one of the biggest worries that dentists have about doing oral appliances for snoring and sleep apnea is what changes to the bite are going to happen. Well, guys, they're going to happen. It's just inevitable because some people don't do what they're supposed to do. But in fact, you can help mitigate that by giving them a high quality reset device and some instructions. And as you see in the middle of the screen, and you'll see later, all the Glidewell devices come with an AM aligner. So it's a great benefit of having this device from here. And there it is. There's a better picture of it. And this is the best way I've ever found. And there's lots of different ways to do this, but there's nothing as easy to use or as reproducible as the AM aligner. So make sure you get some of these. And if you're using devices from another manufacturer, you can order a box of these directly from Glidewell here. And then that way you can provide those if you're going to use somebody else's device, so it doesn't come with an AM aligner as well. The other thing you can do is some simple physical therapy. Here's one of the things you can do. As you can see, we call it the thinker pose for a reason. And what they do is they put the front of their chin, not the underneath their chin, the front of their chin in the palm of their hand. They tip their head way down, teeth apart just a little bit, and they think about driving the front of their chin through the back of their head. What does that do? Think about the anatomy. It stretches the inferior lateral pterygoid muscle. And that's what our goal seems to be. We don't have a lot of science behind what changes in the jaw joint to produce that forward posture through the nighttime, but we do think that we need to stretch the inferior lateral pterygoid muscle. And when we do that stretch, that gives us a good chance of recovering MIP every morning. So they can do this anywhere, anytime, all through the daytime. And we have lots of people using this exercise. It's super easy for them to do. So another question that comes up is, well, how do I know that this patient is a good candidate for an oral appliance? Or conversely, they're sitting in my office and they say, I can't use my CPAP. Well, some pretty good science has come out lately. And what it shows is that if we look at the details of the sleep study, and we look at the differences between the numbers of hypopnea events and the numbers of apnea events, if we have somebody who's mostly hypopneas, in other words, they're still moving air, but they have to move less air, so we have a greater than 58%, pretty specific number. If we don't desat that deeply, I mean, 82.5% is a pretty deep desaturation event, but it's not as low as they sometimes ever get. And if we have mostly overweight or normal weight people, so not the obese people, then any two of those characteristics predict poor CPAP compliance. Now, there's reasons why this correlates with what Dr. Eckert showed us about why people have sleep apnea, but we don't have time to get into. But this is something that you can look at that study and agree with your patient that, in fact, the CPAP wasn't really a very good idea. And that puts you on the side of the patient for managing their perceived benefit. So this is a good thing for you to look into that sleep study and think about this, because our friend Kevin Quishan, and if you ever see an opportunity to hear Kevin Quishan speak, you should take that, because he's an excellent teacher. And he had this on a slide years ago when we were teaching together. And I said, Kevin, I'm going to use that for the rest of my career, because this truly is a thinking person's game. And that's the fun part, because we don't just pull the same device off the shelf for everybody. We don't just listen to the patient's story. We don't just look at the sleep study report and automatically know what's going to go on. So I'm going to tell you some things about appliances today, but it depends on you to think through this and to know your patient and to know your work enough, like Dr. Penke said, to be able to apply your knowledge appropriately for this individual case in the chair. And if you find yourself doing the same appliance over and over and over and over again, you want to be questioning whether you're actually thinking through this well enough, because there is nuances that you can make to where your patients have now the best chance of actually using the therapy that you prescribe. The one the patients will actually use is your favorite device. So we have to apply this knowledge. Too many people learn these things, but they don't think about it in their day-to-day clinical life, where they make excuses for why they don't have time to do this or don't have time to do that. And meanwhile, half of their patient populations in their practices are not breathing well at nighttime, and you dentists can do something about that. And we dentists as a profession must do something about this, because there's not enough physicians doing enough to help people breathe. So I'm going to talk to you about custom mandibular advancement devices, and there's more than 120 different devices that are FDA cleared. These are medical devices. You can't just buy them everywhere. They have to be specially certified by the FDA, because we are treating a medical condition. Now, if you have a patient who has a sleep test done and they don't have a defined medical condition called obstructive sleep apnea, they may have a breathing disorder. There are some breathing disorders called upper airway resistance syndrome, pure snoring. These are all problems with breathing at nighttime that don't rise to the level of a medical defined disease. Doesn't mean you can't help these people. If you have somebody that goes through a sleep test and they come back and they don't have obstructive sleep apnea, but they snore, well, you can help them. And you need to help them, because they'll feel better when you do that. You might have a patient who complains of some somatic problems like migraines or TMD or even fibromyalgia or polycystic ovary disease. These are all linked to poor breathing. There's a bunch of others as well. And we can help them, and we need to help them, because if you go to your sleep physician or your patient goes in and says, Doc, I don't think I feel good because of these issues, and they do a sleep test, and in fact, they do not rise to that level of diagnosis, then that sleep physician has nothing to do that they can help them with, because they won't prescribe a CPAP for somebody with a few disruptions. They won't prescribe a CPAP for somebody who only snores. But we can help them by using one of our custom mandibular advancement devices out of the many that we get to choose from. And some of the major advantages we have with this is we can actually send somebody out with a device tonight. If you have a patient that says, man, I fall asleep every day driving home from work. you don't have to send them out of your office with no solutions or some solution that requires months of diagnosis, hoop jumping and getting your appliances in place. You can make a device tonight to make them less sleepy tomorrow while they, in fact, go through the eventual diagnosis. Yes, but we can help them right now. Oftentimes, we see people with structural compromises. They have really small jaws. They didn't get proper expansion when they were kids for orthodontics. They have lots of reasons why they have a compromised airway. Well, we may see a bigger term solution with surgery or orthodontics or some other expansive kind of thing, but they're not ready to hear that. We make them a mandibular advancement device and we help them breathe better. We help them feel better and they get a proof of concept. And that might spur them on to finding a different solution. Or we have people that have a CPAP and they just can't stand it anymore. And we're going to make them something now that will help them out. And so they can give them an alternative to CPAP. Now, lifetime, they may go back and forth between oral appliances and CPAPs, but that's another conversation. So what can you do for them right now tonight? You can make them a MyTap, and a MyTap is a thermacryl, again, that same material that we make the AM aligners out of, is formed into these arches with a adjustment screw. And so the MyTap is heat molded in your office. Patients don't make this, you make this. And as you are able to conform this over the teeth, the patients can then adjust their mandibular protrusion until they solve their problems, until they're not snoring, for example. It does come with a silicone cover that you'll see a different picture of in a minute, and that will help them be a nose breather. And it also has accessories. And so you can vary the vertical dimension of the jaws there using these little props that go over top of that stick. Very, very easy to make. It takes about 20, 25 minutes in your office, costs about $80 or $90. And so you can have people that are extra sleepy, or they just can't stand their CPAPs and they want something right now, or they've lost their custom mandibular advancement device or some other reason, and you can make them this in about 30 minutes and send them out the door. These last quite a long time. You can remold them over and over again if you need to, and it's a very, very handy device to have. If you're doing mandibular advancement devices in your office, I think you need to stock some MyTaps, because somebody's going to come in and say, oh, I stepped on it. Oh, my dog chewed it. Oh, I left it behind on a trip and I can't stand the thought of sleeping without my device. And what are you going to do to help me? And so a MyTap is an easy way to help them right now. One of the real popular devices is that EMAs. The last, you can see the name on it. So the EMAs, we make a ton of these in our office because they're very well accepted. These come with a number of different bases. From Glidewell, they have a printed base like this, or a acrylic base. And what you'll see is those little straps on the side. It's yellow on this screen. There's also blue ones, white ones, and clear ones. So you can vary your patient's ability to move their jaw with the color of the strap. That makes it very, very handy for somebody with sore jaw muscles. If you have a TMD patient that you want to help out with a mandibular advancement device, you can make them an EMA and give them a white strap, which is very flexible, and they can move their jaws all they want. They can grind, they can clench, they can brux back and forth. They can stretch the heck out of that white strap and have to get a new one pretty frequently, but it's very comfortable for them to wear. And so they're much more likely to feel the benefits and actually wear the device that you're using. And then once they're more comfortable, less trouble with their TMD, you can put them into a more rugged strap like the yellow ones or the blue ones, and they get a chance to have it last longer. So it becomes a very, very flexible device for you to use for individual patient care for this, for the using the EMA. And you can master this one pretty quickly. The Silent Night 3D is a new one from Glidewell, and it's kind of hard to see on the screen because everything's clear white, but it's got a very well-fitted base that they print up, and it's got those little pieces on the side that you use to advance the jaw. So you have different pieces on a stick. They're I guess they're probably injection molded, but what happens is you change those out, and that moves the jaw further and further forward so that they can titrate their open airway. And this one's going to last a while. And because it's precisely fitted, because it starts as a digital way of creating it, it's going to be a good one to use after like a clear aligner therapy where people are a little nervous about whether they can, their teeth are going to move again. This one won't let them. It's a retainer as well as a mandibular advancement device. And so pretty easy to use and adjust in 0.5 millimeter increments. So it's a pretty flexible for your patient care device. This one's been around a while. Silent Night has gotten better and better and better over the years. And this one I always think about as a interim device because honestly, this one is not robust. That little strap on the side is a weak spot. And so what happens here is patients can use this. They get a great proof of concept. It doesn't cost very much to make one or two of these. And so you can use this in your practice to help patients with snoring where you don't have to charge them a lot of money. They're not going to get any reimbursement this way. But it may not last as long, which is totally fine if you help your patients understand that limitation. So you say, let's try this out. It won't cost you very much. Let's do this. And if you love it, we can keep making these, or we can make one that's a little bit more robust. All kinds of ways you can use a Silent Night. It's a very good device, but I don't think it's a long-lasting device. Not like some of the others that are available from Glidewell or some other places. This one is a long-lasting device. It's very well made base on that one. And it's got a hinge point, they call it, which is a adjustable screw mechanism. So it has metal on the side. It's got a threaded rod in the middle of that very short device. So it's very handy for your patients with a short arch. And that threaded rod can be adjusted with a screw and screwdriver. And then the patient moves their lower jaw forward until they find that sweet spot where their airway stays open at nighttime. Now, the robustness of this is that this has allowed it to become listed as a PDAC device. Now, PDAC means that Medicare approves it. And if you're working with medical insurance, that's an important distinction. Not that you always work with Medicare, you can, and I encourage that, different talk as well. But many of the other insurance companies are also using that same listing. So when we see that fixed hinge like this, then we can use it for our patients who have that restriction on their reimbursement policies, on their medical policies. And other people can tell you more about that, or we can at another time. But one thing I want you to notice about the Glidewell hinge here is look how short it is. It only extends from, on this particular picture, from the upper first molar area to the lower first bicuspid area. Well, how do many of our patients approach us? They approach us with a history of 4 bicuspid extractions and a very small arch. There's not a lot of anterior posterior room on that arch. The arches are short. If you have a long device on the side, then it may not fit that arch very well, and we end up interfering with how the lip functions. So I love the Glidewell short hinge. It's very, very handy for lots of patients. Okay, here we go. And then the Flex Tap is a newer device from Airway Technologies. This one doesn't need a bite registration. And we didn't talk about bite registration. That's another talk. I'm sorry about that. But this one, you can take just 2 scans and you're good to go. Even impressions can be good to go with a Flex Tap. And the Flex Tap is what it kind of says. It's a heat mold. That's another thermocryl material. It's blue this time instead of white. But what it does, it fits very, very comfortably on the teeth. Flex Taps are great for people who have a lot of porcelain restorations because they've paid a lot of money for these restorations. They don't want anything to scratch these porcelain crowns up, and they don't want to risk those. So Flex Tap is fantastic because it feels soft on all the teeth. And like the MyTap, it has a protruding adjustable knob. And so the patients get to titrate their jaw position until their airway stays open and achieves the goal that they're looking for. Very comfortable device to wear. It feels soft in the mouth. They can grind and clench on it all they want, and it doesn't hurt anything. So it feels easy to wear. The Tap 3 gets to be a little bit more robust and custom device. The bases are heat molded or milled, and the Tap 3 has a connector in the front. Now that single connector in the front, kind of like the MyTap, allows the jaw to hang forward. There's a little hook underneath what that metal part is incisal there. And the patients who, when they roll on their back, have a terrible time breathing are best served by these devices with a single anterior connector because it's like hanging your coat on a hook. The lower jaw just can't fall backwards. The TAP 3 has an advantage because it's a small connector in the front, and it's a pretty good device. I've used a lot of TAP 3s over the years. They last a long, long time, but Airway Technologies came up with another device called a Dream Tap. And I like this one even better for you because what happens here, just like the TAP 3 and the Flex Tap, it has a single anterior connector. This time, there's a little hook on the lower, and it goes over a wire on the top. And what isn't apparent on this picture, sorry, is that the jaw can move back and forth quite a bit here. So left and right, there's a lot of movement available on that hook on that wire. So it doesn't lock the jaw in. It's really good for patients who have a history of TMD issues because they can't clench very well on this when their muscles kind of shut down. And they can move around so the jaw joints are not locked into place very well here. So I like TAP 3s for that. You put a little key in the front and you can advance the lower jaw on a continuous screw. So that means that they don't have a jump. When we think about like the EMAs, or you think about the Silent Nights, when you change the little connectors on the side, then it jumps the jaw forward, which for most patients is totally okay. But some of your patients are going to be real tender about that. And they can't move from a number 18 strap to a number 17 strap very comfortably. But with something like with a continuous screw, like any of the TAP devices or the Glidewell hinge, then you can dial that lower jaw forward in very small increments. And so people can feel like they can titrate their jaw very, very easily, very, very uniquely for their own needs. And then the biggest thing that comes with a Dream Tap, it also comes with a Flex Tap, is this shield. Now, on what I call a nasal breathing trainer, the company calls a mouth shield. But picture what happens here. What this is like is when you have your device in place, this silicone cover goes in front of the device over and over the teeth here under the lips. And that means that when the lips fall open a bit during sleep, it still doesn't allow mouth breathing. So it still forces nose breathing. And I've talked about nose breathing in March when I spoke for Glidewell, and I'm a big nose breathing fan. And I believe that all these appliances should be able to prohibit mouth breathing for most of the time and help people develop a nose breathing habit. So if you know me at all, you know I'm going to be a fan of nose breathing. And I like this addition to the Dream Taps and the Tap 3s. And it comes with the Flex Tap and the My Taps because of nose breathing. So another device that you can buy from Glidewell is called Oasis hinge, kind of like the Glidewell hinge, but look at the side device. It's much longer. And so be careful with an Oasis hinge if you have a real short lower arch, because the front part of it there can interfere with the corners of the lower lip. And so I don't use these as much as the Glidewell hinges because I do like that short hinge, and it also adjusts in a very similar way with the threaded screw on the side. If you go away from Glidewell and you have some other devices, I want to tell you about some of these others because they're real popular. Dorsal devices are real common, and this dorsal is a generic term for having a acrylic, generally acrylic, post on the lower against an adjustable device on the top. So on this particular device, the part on the top is adjusted with a pin in a continuous screw, and so you can dial the lower jaw forward using this one here. Now, this is a very common device. It's also very comfortable for patients to wear. It's an older device, and it's more bulky than most devices these days. So I don't use this near as much as I did when I first started, because now we have many more choices, and we've recognized that increasing tongue space is very, very valuable. And so all of the devices I've shown you so far have a feature that includes more tongue space than the dorsal devices do. People like this one, though. It's pretty comfortable to wear. Another material that you'll see a lot in the marketplace is printed nylon. And there's only one nylon. It's called nylon 12. It's an FDA cleared material. And a whole lot of companies are making devices that hold the jaw forward using this same material in different ways. These two particular examples here, one of them has a strap on the side that has kind of like the EMA straps. It has different lengths to use. And as you change those lengths out, the lower jaw comes forward. The one on the top has a mechanism built into it where it has interlocking blocks, and those interlocking blocks keep the jaw forward and keep it from falling backwards. The key to printed nylon is that it's really tough, and so your patients who are big time clinchers or bruxers, or maybe you've used a silent night on them and they've destroyed it pretty quickly. You think, okay, what's tougher than that? What can I give them that will hold up to what they're going to do at nighttime? And I think the nylon is the toughest material we have out there. It lasts a long time for most of those patients. And so I use that. Now, one of the keys for any nylon device you might choose is understand how well that the manufacturer has mastered the polishing process. And there's the best company out there for that is Panthera. They've got the best polish on nylon. There are other manufacturers that have not yet mastered the polish on the nylon, and you'll end up with patients complaining about the rough feeling of the nylon surface. So be careful about that one when you're going to nylon. Another common one out there nowadays is milled acrylic, and lots of companies are making milled acrylic devices where you get a block of highly processed methyl methacrylate, typically, although some of the companies now are using some proprietary materials, and they mill this. Now, if you have a patient who says, look, I just finished clear aligners, I finished my braces, I can't stand the thought of wasting that money and having teeth move, and I have to wear retainers every night. What have you got for me? Well, now the new Glidewell device, the new Silent Night 3 device is really excellent. But in the past, we've had these milled acrylic devices as our best choice. And they're kind of pricey, but they fit, and they fit very tightly. You have to have a super precise scan to be able to make these properly. But when you get these done, patients feel confident that your teeth won't move. And these come in different forms. There's little posts on the side on some designs. Some of them are PDAC approved with a hinge on the side, and some of them have a adjustable dorsal design as well. So milled acrylic is a popular one out there. You might try some of these later on. They're a little more challenging to get fitted because if you don't get everything precise, it won't fit well. But when you do get it right, it's like a great fitting pair of shoes, and patients love these things. And here's a unique one too, called Avant, made by one company. And this is milled. It's milled, has two milled surfaces. The outer surface is a milled hard acrylic, and the inner surface is a milled soft acrylic. And this designed to allow people to change that blue strap, and that holds their jaw further forward. Kind of like the anterior posturing device, or anterior post device. When people are sleeping on their back, this is a good device for them not to have their jaw open or fall backwards. And so I like that one for them. It's a little bit bulkier than some of the other devices, and so that's a kind of back to that dorsal design, but it does work for people with fairly large arches, and especially for clinchers or grinders, because they can do that combination of moving their jaw back and forth because the blue strap doesn't restrict them, and lots of acrylic to support that pressure that they might be putting on their device when they clinch at nighttime. And then here's a new device you probably don't know about called Somnoseal, and you can get this from somnoseal.com. A friend of mine, Dr. Kim Hutchison, she's a sleep doctor in Portland. She showed me this, and she said, Steve, I invented this because my CPAP patients were having trouble with air leak out their mouth. And as soon as I saw it, I said, Kim, this is perfect for my oral appliance patients who don't have a mouth shield or a nasal breathing trainer to go with their device. Because what happens here is after you put your oral appliance in, then you slip this in under the lips, and it makes you a nose breather. So I use this myself with all of my devices, and I have several devices that I use because I like to use several different devices. And I use this under my lips, and it makes me a nose breather, and it improves my sleep quality, and I like it much better that way. And so Somnoseal is something you can get for patients who complain about dry mouth using any of the devices that you might choose. Most complications with our appliance therapy, other than getting the bite back to normal, are super simple. You can make any device fit in the mouth. You're good at making the acrylic devices fit, so that's really not a problem, especially these days when we're using scanners mostly to make these impressions. If you're using regular impression material, make sure you use a very high quality impression material and take a great impression like you would might for a partial denture, and then your manufacturer can make a great fitting appliance. If you give them a bad impression, like an alginate or some other thing, then you're not going to be able to confidently go to delivery with a great fit, and you'll deal with complications later when they complain about how it hurts this tooth or that gum. So if you give them give the manufacturer great information, then you'll get a great fitting device, and that ceases to be a problem on all of your patients. Other things have to do with the transition from poor breathing to good breathing, like when you have more parasympathetic uh, sleep, you're going to drool more for a little while until you don't. And so you warn your patients off on that one. But all these are short term. All these are easily managed in the office. And now that we have the AM aligners, then even the bite complications are no longer much of an issue for our patients. It all has to do with their adaptive capacity. And this study was done really well, just published this year in March. And they studied a lot of patients' perceptions of how they do with their mandibular advancement devices, pretty spot on. And they said the advantages perceived by the patients, there's that perceived word again, outweigh the disadvantages, especially the things that they care about, like feeling better. And the side effects are reversible, short term. And most importantly, occlusal changes, the thing that dentists worry about, are not considered important by the patients. And this bears out in my practice over 26 years. And I'm a Pankey trained dentist. I love a good occlusion, but lots of my patients don't have a good occlusion anymore. Not lots. A number of my patients don't have good occlusion anymore. They don't care. I care. Their dentist cares. They don't care. So it's really not, don't hang up your practice on, or don't avoid doing mandibular advancement devices because you're worried about bite changes. That's not going to be a factor for you as you go forward. So what's a quick guide for doing these? Get to know your patient. And it's really great to ask them, well, what do you think would be a good device for you? What features do you look for? Now, they're not going to tell you, I want a flex tap. They're not going to tell you, I want a silent night. They're going to tell you, I want to be able to open my mouth. I want to have a small one. I want to have something that doesn't have metal in it. And so they're going to tell you what they might be thinking, and you can apply your knowledge to match that patient with a device. But in general, if you have somebody who's a grinder and a clincher, think about something like an EMA or a Dream Tap, because that allows them from freedom of motions so they won't feel locked in. That'll be helpful. If you want, flex tap could kind of work there too, but I like flex tap for people who say, well, I can't have any metal in my mouth, period. End of story, no metal. Well, flex tap's great for that. So is the new Glidewell 3D device. That's a really nice one, and it looks good and professional looking, and it looks high quality. If they have come in and say, you know what, I've chewed through all my bite splints, or you've made them a couple of mandibular advancement devices and they just keep breaking them. Well, there's nothing better than that printed nylon one from Panthera. I think it's really strong. And Avant is an excellent device also for these people because they tend to hold up quite well in my history so far. Other things you can think about. I mentioned PDAC. That's the CMS. That's the Medicare. That's the private insurance now. Several of those companies are making sure that their devices you deliver are on that list. And if you provide one on the list, then they can get reimbursement for their medical insurance. If you provide one that's not on the list, then they can't get reimbursement, and that's a big deal. Or if you provide one not on the list and they apply for it and they get reimbursement, that money can be pulled back, and that's a big trouble. So don't do that. If they just finished a liner therapy, like I mentioned, get one of the milled devices. The new 3D might be excellent for that because they require a digital workflow. That means a precise fit. So that's a very good match. And then if you have somebody who can move their jaw a long way forward, I mean, 10, 15 millimeters forward, there's people out there like that. The Avant has the longest range that I know about in the industry right now that can, so they can track that forward. Not most people don't need to go to the maximum that they can protrude their jaw, but if you have somebody who's insistive that they are able to do that, well, there's no device that matches the Avant's ability to move that far forward that I'm aware of. And the metal ones, like the Glidewell hinge, there's a limit to how far they can go, and then the as the further out that metal hinge is extended, the weaker it gets. So if you have somebody who goes a long way out and clinches and grinds, they can bend that little hinge. That's true for all of the metal, all of those adjustable devices on the side, no matter who makes it. So the most important thing to think about is when you have somebody that wants to tell their story, and you take time to listen to that, then you can properly match your appliance to that particular patient's concerns. And then if they come back with trouble, most of the time, what they just want to be able to vent and tell you what their problems are. And if you listen very carefully, you can figure out which pathway is going to be successful for fixing those complications. And there's not a lot of complications that come with these. It's pretty easy to make these devices fit and be comfortable for your patients. So don't forget, in the big scheme of fixing poor breathing at nighttime, we have CPAPs out there, and they're wonderful. I love CPAPs when they work for people, but less than half or less than 30% will actually use the CPAP. So it's not a universal solution. It does fix the event count just fine. The oral appliances do a great job of fixing the event count, not as good as CPAPs for most patients, but more than 80% of people by study will comply with your appliance all night long. And so we come up with something called mean disease alleviation, which means how effective is it and how long do they use it? And there's a whole lot of studies that back this up. But in general, what I'm showing you here is the mean disease alleviation is the same. CPAPs and oral appliances do the same medical benefit across the board for mild, moderate, and severe sleep apnea. So we don't have to take a second seat to CPAP when we're thinking about population health and what we can do to help people. And so as you talk to your physician colleagues, they'll say, well, CPAP does a better job. It does a better job in a narrow definition. It doesn't do a better job in helping individuals. And so patients in your chair need your help. This study was done by Pristine Medical Building a few years ago, a couple of years ago now, and it turns out that oral appliance therapy in general with medical insurance coverage is cheaper than CPAPs. So they don't have a financial advantage over oral appliances either, and by a considerable margin, because people forget that you have to keep paying for supplies for the CPAPs, kind of like printer cartridges. You have to keep buying the silly things. And so oral appliances cost more upfront, CPAPs cost more in the long term. I want to close here. I know I'm running overtime. Sorry, guys. Is that Collaboration Cures is coming up in September. It's a great event if you're interested in airway and general health. Take a picture of this, and you can go to the website and have a look at that. And we have a lot of great speakers coming up. To learn more about this, AAPMD is a great organization, has a lot of webinars. Of course, Glidewell has wonderful webinars. I mentioned Jameson Spencer has a bunch of good ones on there. And then AADSM, American Academy of Dental Sleep Medicine, has a mastery program that probably is your best complete way of learning about this at this point. So gone through this now, Nicole and Dr. Park. So let's have a look at some questions.
So thank you so much, Steve. This was great. Really, as always, a great lecture. And let me just tell everybody, we're going to go ahead and give 1.5 CEU hours. We're going to keep Steve here a little longer and try to answer a lot of your questions here. Okay. But the boss, Nicole, has given us permission to give 1.5 CEUs. So Steve, are you ready? It's going to be rapid fire.
Let's
we have
go.
a lot of questions and they're good. So this doctor made an EMA appliance for a patient with severe snoring, but normal AHI.
Right.
And we've got her all the way up to the number 16 blue rubber band and she's still snoring. What do I do?
Well, it could be that moving the jaw forward just isn't going to solve all the problems. And so I think about an ENT consultation at that point to see if there's a restriction in the nose, because if you pinch the airflow through the nose, it's going to make more noise in the back of the throat. And the other thing you can think about is more vertical. And so on EMA, it's really easy to add some acrylic to that and maybe make the jaws a little further apart so you further stretch the jaw down as well as you go forward. So those are two strategies to go for on that one.
Great, great. Um, Here's an interesting question. A lot of us operate under the theory that bruxism is related to this inability to breathe, to this, sleep apnea.
Mhm.
Um, have you found that as you treat patients with mandibular advancement devices for their apnea, that bruxism decreases?
I do. What I tell people all the time is, look, probably you're grinding your teeth because your brain's getting awoken by this bad breathing. And so we're going to help your breathing better. And so most people that breathe better at nighttime have better quality sleep, and they stop their bruxism, except for the ones that don't stop their bruxism, because bruxism is multifactorial. We don't know why people do it all the time. It's certainly not 100% from airway. And so what I do always then is I take that into account and I can build them a device that will take what they're going to put out. I assume they're not going to stop their bruxism because some of the devices that we can make for them will be able to take that and also provide airway. And if they airway support, and if that happens and they stop the bruxism, great, the appliance still works. If it doesn't stop the bruxism for a short time at least, while their body resets to better homeostasis, then the appliance won't break down. So I'm careful with what I choose.
Okay. And sort of as a follow-up here, what's the best appliance choice for someone that has a TMJ issue and diagnosed with OSA?
Well, obviously, it depends on the TMJ issue. If it's a capsular problem, that's another story. If it's a muscle pain problem because they're overusing their muscles. I love an EMA for those patients because we can vary those straps on the side from very flexible to very rigid, and we can allow those muscles to relax and while we support the bite in a more forward posture. And also, don't forget that if you have a condyle in the fossa, the muscles can work with a lot of efficiency to chew through hard things. If you take the condyle out of the fossa by moving it forward, that decreases the muscle efficiency by a huge amount. So the amount of pressure they put on their teeth when they have their condyles seated is way different than the amount of pressure they can put on an appliance if the condyle's forward.
Okay, and I'm gonna go into this question, which is a little bit of repetitive, but just to make a fine point here. So if someone has a pre-existing TMJ issue, you would go ahead and do appliance therapy, but you would choose something like an EMA.
Well, it depends. Again, you have to it's a thinking person's game. So if they come in and man, their jaws are killing them and they can't open their mouth because it hurts, you got to fix that first. And so another person who's done some education for you, Bradley Eli, has a facial pain emergency kit. And I don't know if you guys have stocked that one, but it's a really good one. It has aqualizer, has some treatment. So you get rid of the acute problems first. And then you can make a mandibular advancement device because oftentimes, if their jaws are hurting so much they can't move their jaw, you can't scan them either. And so you give them something in a deprogrammer or an aqualizer or some other thing, and you get their acute problems. And then you can do safely a mandibular advancement device. Now, if somebody comes in, like I said, their jaws are just a little sore because they clench every night, I don't have any trouble making them mad right straight away.
Great, great. Um, a bunch of questions here about nose breathing, and as you said, you were here in March and gave a wonderful lecture. I have to tell you that I purchased this SomnoSeal device.
Yeah,
Fantastic,
isn't
works
it great?
100%. I am a nighttime nose breather. It's really made a huge difference. So what is your opinion of mouth taping? We have a doctor that wrote in and said he does it on himself and it helped
Yeah.
him. Other people are curious. And also mouth taping versus this SomnoSeal device.
Sure. Well, keeping the lips together is what's important. Nose breathing. Using a piece of tape over the lips is one way to do that. and you do that with medical paper tape. So you just put the lips together, you poof them out a little bit, put the tape on there, and then it just keeps the lips from falling open during sleep, and that promotes nose breathing. The Somnoseal does the same thing on the inside, but without the sticky part on the outside or the appearance on the outside. And you can just rinse it off, as you know, every night or every morning. And so you can use it over and over and over again. So it's a little easier to manage, but they both do the same thing. So I don't have any trouble with lip taping. I know I have lots of friends who lip tape every night. I've done it for decades, it seems, and they do it because it creates a habit. Now, what I tell patients is when you do the lip tape, after a while, check and see if you still need it. Because once the body gets into the nose breathing habit, that's where they needs to be. That's homeostasis. And so if the body says, "Oh, I like that," then you don't need lip tape anymore. But when people are in a habit of mouth breathing or forced to it, then we get a nasal disuse syndrome, which plugs up the nose. But when you breathe through the nose all the time, your breathing gets easier and better through the nose. And so you can change the habit.
So the first time you said that, I did not believe you, and I can tell you now that you're 100% correct. That it's kind of a disuse thing, and once you get into that habit and you sort of force that habit, it works a lot better. So thank you for your wisdom on that issue. How do you address a patient that has an allergic situation where they just can't breathe through their nose? It is the same situation. They've got to go through. They've got to use medications to open it up.
Yeah, but you give them a chance to breathe through their mouth. So you don't give them a tap with a mouth shield. You don't put a Somnoseal in it, with tape on it, because they got to breathe, right? And so nature gives us two different ways to breathe because this plugs up. So you don't fight that. You don't tell them that's their only option, rather say that, but you do address it. So we do sleep hygiene issues like going to the ENT doctor, using Flonase from Costco is perfectly fine. Using clear nasal spray, which is saline and xylitol, getting an air filter in the room, getting the dog off the bed. I mean, whatever they can do to improve their nasal physiology at nighttime. Sometimes even just elevating the head of the bed. So if you put two two-by-fours under the bed frame and raise the head of the bed 3 inches, that changes the fluid dynamics in the whole head and neck. And so you can decrease the amount of fluid that builds up and you can make your nose easier to breathe through.
Great, great. Here's an interesting question. Can you just give us shed some light on pediatric snoring and sleep apnea? I mean, is it treated in a different way? What should it be our approach to that?
Yeah, it's a whole different thing. We don't do mandibular advancement devices for little kids because it just doesn't work that way. So when kids are snoring, first of all, that's a big giant red flag. Do not let your parents think, "Oh, that's so cute. Look at my little daughter, she's snoring," and think there's nothing of it. When you go to the pediatricians, they'll say, "Well, they'll grow out of it," which is probably true. But the brain is affected by poor breathing during growth and infancy. And so if you have a brain that's affected for 12 years while they're growing out of it, is that the same brain you would have if they did breathe properly? So don't let snoring be overlooked. Now, what do you do about that? Typically, it's allergies. Typically, it's sleeping posture. Could be expansion of adenoids and tonsils, which are partly an allergic response. And so you need to aggressively go after that. And then it's something that you can ask. The parents can ask the pediatric dentist or the primary care dentist who sees kids about, well, is that bone growing properly? Because when a child has an open mouth posture while they're breathing, unlike you and me, Neil, it's also affecting the growth of that bone. And so an open mouth posture is what ends up with a long face, what ends up with a narrow arch, which ends up being 45 years old in my practice with high blood pressure. So.
Absolutely, absolutely. Somebody's asking about an appliance, and I can't think of the name of it, and this doctor couldn't think of it either. But it was something that you would sort of stick on your tongue,
Yeah.
insert your tongue in it, and I mean, I've got colleagues that swear by it. They think it's great. We used to sell it at Gladwell. We don't sell it anymore because it's
Good.
available on YouTube or
Right.
Amazon or whatever. But what do you remember the name of that?
Avio TSD. And
Ivio, right.
yeah, and that's the one you guys sold, but there's a number of others on the market. But the first device that was ever made for holding the airway open with an oral device was a tongue retaining device. And it's think about, pulling a suction in a bottle, sticking your tongue into it and, suspending the bottle with your tongue. It's that same principle. And it works great. When you have the tongue forward using a suction device with a flexible material, it's a fantastic way to keep the airway open. Sadly, people won't do it because it makes their tongue sore. It's weird looking. It feels strange to have your tongue pulled forward that way, and it's not a long-term use by anybody.
Yeah, I tried it once. In the morning, it tended to be on the other side of the bedroom in the far corner.
Yeah.
kind
Yeah,
of
it's not a viable product anymore.
Right.
No.
Right. But if you're interested in it, we don't sell it at Glidewell, but you can get it on Amazon very, very inexpensively.
Right.
Interesting question here. Okay, so you talked about the AM aligner and how it's important to get the occlusion back in the morning. This doctor says, I recently had a patient wearing an MAD for many years. His occlusion was just on his anterior with an open bite in the posterior.
Mhm.
You did very clearly talk about how to prevent this from happening, but once it's happened, what do we do?
Well, here's what doesn't seem to work is when I've given people physical therapy tools to use, a tab, like a leaf gauge in the front, exercises, it doesn't seem to make any difference because what the anatomist told me, and some of your listeners may know Henry Gremion from years ago, but Dr. Gremion was an expert on jaw joints. And I said, Dr. Gremion, what do you think is happening here? And he thinks it's fibrosis of the inferior lateral pterygoid muscle, which you're not going to recover from. Other people, I've taken x-rays on people in that circumstance, and the condyle is still centered in the fossa. So we think the condyle is adapted backwards with muscle pressure. So I think that happens. I think the alveolus sometimes slides forward on the mandible. Sometimes I think the teeth tip. So the recovery from that is not always non-invasive. You might have to, if you need to recover from that, and the question would be, recover from what? Then it's oftentimes orthodontics or sometimes even orthodontic surgery. Now, sometimes that helps because you have patients who have now a forward posturing and their airways just more open. It's easier for them to breathe. If they were a previous orthodontic surgery candidate, it makes the surgery a little easier if the condyle's adapted to that spot. But what I always do is when somebody comes in and shows me this, I say, okay, let's run down the list. Are you having troubles in your jaw joints? Are you having troubles in your muscles? Do your teeth hurt? Can you not chew properly? And I tell you, the number of patients that have answered positive to any of those questions over the years is so few that I just really stopped worrying about it. As a dentist, I hate it. As a patient advocate, as a patient care person, it doesn't bother me at all anymore. And the medical hierarchy of making sure oxygen is supplied to the brain tissue every night way overcomes the fact that the teeth don't come together anymore.
I think that's a well put point. That you're successfully treating their sleep apnea, they're breathing, they're getting all the health benefits that come along with that, and maybe that's the price you pay, is that you may have an open bite of the posterior, and as your survey pointed out, people don't really seem to mind that. It's not a big issue. Steve, I've got a bunch of questions here about insurance coverage and getting payment. You and I have both worked with a company called Pristine Medical Billing. There are some experts in the field out there, and I know it's a lecture. I've done a whole day on it. But do you want to make any kind of comments just to give a general framework for people to have some understanding of the issue?
Yeah, the general framework I'd say is if you're not well versed in medical billing, then hire a medical billing company because they know the nuances of this. And remember, no insurance company, whether it be dental or medical, is in the business of paying for healthcare. They're in the business of making money. And so
not paying for healthcare.
Exactly. And so so every dollar they don't pay you is another dollar for the CEO's bonus money. And so that means that we have to kind of force the insurance companies to pay. And that means there's very specific requirements. Here's a quick example. if you give somebody a home sleep test and you show that they have sleep apnea, even if it's read by a sleep physician, so you get an actual medical diagnosis, your device isn't going to get paid for because that you made the decision to do the home sleep test. And so there are certain steps that have to be done. A physician has to decide on the test, and that's important. So we have to have documentation of these things. Well, you learn that from a professional medical billing company, and you mentioned Pristine. That's a favorite of mine as well. So these guys know what they're doing, and they can walk you through it. Now, if you're going to use medical billing, that means you have these rules, and that means you have to use a FDA cleared device, and all the Glidewell devices are FDA cleared for this, so it's not a problem that way. And you have to be able to show a PDAC list if that's important for that particular coverage. And like, for example, up here, we have I practice a mile away from Microsoft, and Microsoft uses an insurance company that requires PDAC listing, which means I don't have all the choices out there that I don't have 120 choices. I have fewer than that. And so I have to hew to those requirements or else nothing's going to get paid for. So it's not hard. It's just precise. It's just difficult, I guess is what I would say.
Right. And even the best of us we're not attuned to medical billing. It's a whole different field. And if you're going to make this a big part of your practice, you're better off hooking up with a medical billing company that can really put you through this. All right, 2 more questions. What about a patient with implant reconstruction? Is there a particular device that you would choose for that?
No, not necessarily. I think if it's a fixed implant, all on fours or something, treat it like teeth, not a problem. Now, I do like the softer liners for those patients because they're clearly all restored, and people like to put a device in place that's a kind of a softer feel for them. So I actually do a lot of the soft liner Avance for those patients because it's just comfortable for them. You can do something a little more flexible. That's where Silent Night might work really well, or now the new 3D might work really well as well.
What about complete dentures?
Complete dentures, if you have a edentulous maxilla, then because the lower jaw is forward, it anchors against the alveolus, and that works pretty well. If you have an edentulous mandible, there's nothing you can do. If you have a couple of implants in place, you can grab onto those. But guys, those are pretty advanced care. And if you're not well versed in doing these things, find somebody that's done a lot of them and send your patients to those folks because these are tough cases, no matter what you do. Yeah.
Okay. Got it. And yeah, one of our friends, Dr. Courtney, suggested a locator retained MAD, which is a great idea. Certainly a great idea.
Yeah, it's a doable idea. And yeah, what I say to patients that come in with dentures, I say, CPAPs are wonderful things.
There you go. How often do these devices have to be replaced?
Depends on what you do to them. If the patient is a clincher, grinder, bruxer, and all that, I have a anesthesiologist in my practice right now, and I got a text yesterday that he broke his latest appliance, and we've gone through 4 of them so far. That I just gave it to him in December, so he's already broken it. And so another one. I have other patients that have walked in and shown me a device that I made them 12 years ago. Just last month, we had a 12-year-old appliance, and it looked really good. And so, there's a lot of variability out there.
Do the insurance companies have a limit on how often they'll replace it?
Generally 5 years, because these are considered medical equipment, and it's generally 5 years. But we have been successful in appealing some of those early ones, and we've been unsuccessful appealing some of the early ones as well. But typically, I tell people they should last 3 to 5 years. Now, some of the best appliances are out there are giving us that level of warranty as well.
Dr. Steve Carstensen, I really enjoy talking to you. You've got so much wisdom to share, and obviously your clinical experience is extensive. And thank you for sharing this information with our group today. Thanks to the panel for great information. And join us next week when we'll have, as always, our business advisory panel. Or Nicole, is that 2 weeks? Are we here next week?
Yeah,
2
happy
weeks.
4th of July, everyone.
Yeah, we're going to be next week's 4th of July. We'll be here the following week, and our guest speaker will be Dr. Taylor Manalili, and she'll be giving us an update on some clinical tips for guided implant surgery. So thanks everybody for joining us today. Thanks, Dr. Steve Carstensen. And we'll see you folks in 2 weeks, and have a great 4th of July. Take care. Bye-bye.
Happy
Thank you
birthday
so
next
much.
week.